there will be fibrosis and hypertrophy. High levels of ST2 would leave the interleukin 33 unavailable for cardioprotection, so that high levels of ST2 have been implicated in several instances like cell death, fibrosis, reduced cardiac function, disease progression. So that's it. The answer there is ST2. NT-proBNP is good for detection of acute onset congestive heart failure. Okay, so may pa-launch ng fifth question. 70-year-old retired university professor went to the lab for his annual executive check-up. While he was at the lab, he admitted to the phlebotomist that he was able to complete the required 12-hour fast and was only able to fast for 6 hours. If this was referred to you, what can you advise this patient? A, may proceed with leave, can only but only HDL and total cholesterol can be done. May proceed with the whole lipid profile testing. He can come back when he can complete the recommended 12-hour fast. If he is unable to do the 12-hour fast, he may opt to do a 9-hour fast. Okay, majority answered B, followed by C, and then 21% answered A, then 12% answered D. Okay, the correct answer here is applying the new guidelines in lipid profile testing. The correct answer is B. May proceed with the whole lipid profile testing. But if we were talking about the old PLAS guidelines or the Philippine Lipid and Atherosclerosis Society, pwede yung 9-hour fast before. This is also NCEP3 guidelines. But new guidelines states that in fact, non-fasting na nga ang buong lipid profile. Before, there are only two components that are non-fasting, HDL and total cholesterol. The whole thing, if you would be requesting outside, if you will be requesting besides HDL and total cholesterol, then it is a 12 or 9 to 12 hour fast. Now we can do this with the new plus guidance. In fact, non-fasting ng lipid profile. Before, acceptable ang 6 to 9 hour fast. So the correct answer is B, may proceed with the whole lipid profile testing. Okay, next question, please. Question number 6. Presenting with chest pain of 30-minute duration, chest pain, heaviness, not really by rest, troponin I. No other tests were requested. How will you interpret the results? We had this previously. A, detected. B, repeat testing. C, unlikely. Unlikely, and look for possible causes of troponin I elevation. %69 answered A, followed by B, and then D, 14%, and C, 5%. So this is similar to the previous question. Remember that off is 0.16 nanogram per ml. Anything that is higher than 0.16 should be interpreted as myocardial damage has been detected. But in real practice, we also need to do a serial testing. But since the level is quite or 100.16, the correct answer would be A. But in practice, we still do or serial cardiac marker testing to detect new onset MI because it's not only the in patients with MI, it's one of the possible complication would be a repeat MI. Okay, next question, please. Question number 7. We're waiting for a question. Ayan. Caucasian female presenting with chest pain of more than 30 minutes. Chest heaviness naturally by rest troponin I 0.19. Diagnosed case of end-stage renal disease secondary to lupus. Latest serum creatinine is 450 micromole per ml. How will you interpret result? A, muscle damage has been detected. Repeat highly unlikely and look for possible causes of troponin elevation for letter D. Okay. Um, Majority answered D, followed by A and B and C respectively. So the cutoff is 0.16, but this particular cutoff has to be interpreted in caution, especially in patients who had history of pericarditis, chest trauma, as well as patients with renal disease since the clearance or the excretion of the troponins are through the urine. So there could just be a decrease in uh, excretion or metabolism of the troponin. That is why it could present as an elevated troponin I, but in reality, this is not yet to be diagnosed as MI since patient has decreased clearance cardiac troponins as a result of the end-stage renal disease and also evidenced by a high serum creatinine. So the correct answer here is letter D. It has to be interpreted in caution in certain situations that I have mentioned. Okay. Question number 8. We're almost done. We're waiting for 8. May pa-share naman ng question 8. Okay. Injuries such as troponins are important in differentiating MI with the following conditions: A. Myocarditis, infarct, pulmonary embolus, and the unstable angina. May pa-relaunch ng question 8. Okay, so the 86% answered D, followed by myocarditis 16%, Then pulmonary infarct and embolus, respectively, 5 and 2%. So let's look at the possible answer by looking at, oops. So the presence or the cardiac markers are being used to differentiate STEMI from unstable angina because it's pag STEMI, you have the typical finding of ST elevation in the ECG, plus you have a positive or presence of cardiac markers. It is difficult to differentiate between STEMI and unstable angina because both would not present with ST elevation. Unstable angina, non-diagnostic yung ECG. So the only way to differentiate unstable angina from STEMI is to determine or have the cardiac markers determined. Because in unstable angina, cardiac markers are usually negative or not elevated, whereas in STEMI, the cardiac markers are elevated. Looking at the other choices, in myocarditis, you don't also have the typical presentation in MI. Like this is the typical presentation, ischemia type chest pain lasting for more than 20 minutes, not really by rest or analgesics, changes in serial ECG, and then rise and fall of serum cardiac markers such as CKMB and troponins, which we see in myocarditis. They have chest pain, but they don't have the typical ECG findings, but in some cases, troponins could also be elevated in myocarditis. Pulmonary infarct, pulmonary embolism, they don't present with the typical chest pain, and they don't have serial changes in ECG, and the markers are also not elevated in pulmonary embolus and pulmonary infarction, yung mga troponins. Okay, now we go to number 9. BNP, na-discuss na natin to, no? Is usually released in response to rapid feeling the ventricles during the last diastole, ventricular expansion due to overload, rapid feeling of the atrium during systole, ventricular contraction as a result of hypertrophy. Okay. 65% answered B. 13% answered D, 3% answered C, and none answered A. So pro-BNP is, the correct answer is B, ventricular expansion due to volume and pressure overload. That is why this is a good marker for acute onset congestive heart failure because it reacts readily to expansion of the ventricles as a result of volume and pressure overload because they are secreted in granules in the ventricles. Okay, okay, so last question. Question number 10. Okay. 35-year-old male was assessed of his 10-year CVD cardiovascular disease risk using the Framingham risk scoring system. Based on his data, he was assessed to have low to moderate risk. Which of the following markers will be useful as an adjunct to his CVD risk stratification? AHSCRP, BNT-proBNP, CST2, and the troponins. Okay, 61% answered A, HSCRP, followed by ST2, 22%, then NT-proBNP, 14%, troponins, 11%. So in assessment, the one of the marker here is used to assess cardiovascular risk progression. So the correct answer is HSCRP. And by the way, HSCRP has been replaced. Wala nang HSCRP na available, so they are now marketing third, fourth generation CRP. NT-proBNP and ST2 are markers of congestive heart failure. NT-proBNP is a good marker for acute onset congestive heart failure, whereas ST2 is a marker for chronic onset or long-standing congestive heart failure. Troponins and CKMB are markers of myocardial injury. Another test that is also used by the Framingham in assessing a 10-year CVD risk is lipid profile, in particular LDL cholesterol. Okay, so if there are no more questions, we cannot yet end our session because there is something that is being asked by the MEU. You have to open your camera, so we have to take pictures. This would be six. We would be taking it 6 times. So I'll just tell you when to stop opening your or closing your camera. Pa-open lang. Just this once. Okay, sabihin ko lang kung tapos na kasi page 6 to we're only with page 1. Okay? Smile everyone. Page 1. Smile everyone again. Page 2. Smile. Page 3. Pa-open ng camera, yung iba hindi pa naka-open. This is required by MEU. Page 4, hindi pa naka-open yung camera, pa-open lang. Don't leave yet. Santo Domingo, Rosauro, Callao, Valencia, pa-open ng camera. This is required by MEU for documentation to make sure that the students are not bots and they are true people attending the Zoom sessions. Pa-open ng camera. Please open your camera muna. I'll tell you na lang when to close it kasi nasa page 4 pa lang tayo. 2 more pages to go. Ignacio Cruz Kimson, please open your camera before. Okay. Ignacio. Okay. Page 5. Pajaro, Pescasio, Rosaros, Ignacio Cruz, Valencia. Pa-open ng cameras, please. So it would be faster for us. Paki-open mo yun yung camera nyo, saglit lang. Pa-open ng camera, saglit lang to. Para matapos na tayo mag-pick ng pictures. Because if your camera is not open and I'll send this to MU, you might be marked absent. Okay. Ay, may page 7 pa pala. Okay. Last page. You may now close your cameras, but don't forget to evaluate. There is a link for evaluation for lecturers found in the chat box. Unless you have questions, we can now end the sessions. Okay, so good luck for your exams on Friday. Don't forget to evaluate. This is also, again, another requirement by the medical education unit that all plenary sessions should have an evaluation. Thank you. And not unless you have questions, I would be ending the sessions now.
Thank you po, Doc.
Thank
Okay.
you, Doc.
Good morning, everyone.
Thank you
Thank
po,
you, Doc.
Doc.
Recording stopped.